like us to start so we can have enough time maybe to discuss some of the issues. Greetings, everyone, and welcome everyone to today's session. We can't wait long for those who will join us along the way. We hope they will finally join us for today. It's been a nice journey that we have taken. In the past few days, we have been looking and introducing end-of-life care for our patients. So this is our third session in 2025. Maybe just to remind all of us is that all our sessions now are going to be held every first Wednesday of the month. So we had one in February on the 5th, and then another one on March on the 5th. So today we are having another one on the 2nd of April, and we are looking forward for another one on the 7th of April. So the topics are getting more fascinating as we go down. So we are just unpacking what we normally know and reminding one another on what are the basic things that we are seeing on the ground. And most of the time our sessions will be comprised of more of case presentations and then some short presentation on that topic for that day. So today we are going to be looking at death and dying across the lifespan, or understanding the reaction and needs of the different groups across the lifespan of the patients. So that's what we are going to do today, looking how do we react to that and interpret it from children up to the adults one. And we remember that in our last presentation, we're looking at factors that influence people's experience of death. And one of the things was the developmental stage of the patient or the family that patient is in. So today we are going to look closer on the developmental stage of the patient, on what exactly is happening with them, and then see how best we can then support them. I think that's what we are most going to be doing today. So with that said, I would like us to continue. I'm hoping I'm audible enough. So yeah. So at this point in time, I would request Tandazile and Mr. Numalo to start the case presentation so we can have time to look around it and then learn from them and contribute where we can contribute so that we can all provide the best we can. Yes, Mr. Numalo and Tandazile, are you ready that I can share the case?
Oh, yes. Good day, team. Yes, you are.
Okay,
we are here, Mr. Masang.
Let me share the case so you can go on, sir.
We highlighted it.
Are we winning? Yeah, boo. Yeah. I think we can go. Can you see the presentation well on that side?
Yes, we can see, Mr. Masang. Thank you.
Okay, we can go.
Oh, yes. Good day, team. Good day. This is Sam Numalo with Tandazilo, or it's Tandazilo with Sam Numalo, Manzini Government Hospital. Thank you very much for this opportunity, sir. Um, First of all, I think we're not sure whether it's the network from our side or is your side, Mr. Matlangu. It's cutting now and then, but I think most of the time we are together. Well, one would have, yes, one would
I
have.
was saying we can hear you, Mr. Muman.
Oh, thank you very much. Thank you. Yes, our case here is not specifically about death and dying like you are looking at in your remarks, but it's one of those cases, and again, one may say that we should be aware that we don't see kids this side probably having a case dead and dying. Kids probably would have been best, but we have this case here, a 72-year-old male with prostate cancer, stage 4, on enrollment to care in 2023. This is a pensioner, a widower. Is diabetic also. It did ocectomy before enrollment to care. Because it's stage 4, we thought this was a pure palliative case because it came here at stage 4. ECOG 3, because most of the time this old man is in bed, could sit up in bed, but most of the time was putting too much for himself. My chief complaint about this gentleman here is that in as much as patient was aware of his condition and prognosis, and the family also was fully aware, the patient was very much worried about his pension payout, which was not fully paid out to him when he left work. I think this one is interesting. I found it interesting because the patient knew exactly what was happening, and upon enrollment to care, the stage and prognosis was fully explained to him, and he understood it, comprehended it very well. That was 2023. So now, and he was fully aware that all we were doing for him was palliative care. So he was very much conversant about his condition. His condition was deteriorating, like I've alluded, that is ECOG 3. Okay, pain assessment. At this encounter, patient complained of left hip pain was radiating to the left scapula. And the pain, most of the time, he said was aching pain. Aching pain sometimes was spastic, that you would have spasms of the muscle jerking off the leg. It had begun some 2 weeks back, and he said it was very severe, according to him. It's 8/10, hence came to hospital for the pain before the scheduled appointment. He said it was intermittent, on and off, and off, sudden onset, without anything provoking it, but you would feel it, and for some time it would subside and come back again. He had a back pain which was well controlled with paracodaine, diclofenac, and it was responding very well. But this time around, he was put on tramadol and paracetamol and amitriptyline, and that was controlled, but will come back now and again. And the pain medication, he said it was effective, but of short duration, and it would come back again. The vitals on our last encounter, blood pressure was 126/84, pulse 88, respiration rate 36, the temperature 36, respiration 18, 96% of true saturation. And in this account, the patient appeared a little bit depressed, was low in mood, was not talking much, only now and again, but then most of the time he would be quiet, only answer that which you ask talking about, and then would keep quiet. A patient, like I've said, was diagnosed with prostate cancer through biopsy in 2022, in December 2022, also did a acute, and it's also diabetic. That was the things he had done before coming to us. And like I've said, the condition was explained, so he knew what was happening, and he knew that cure was beyond cure, just management of the symptoms. And during the course of treatment, he was once put on morphine, paracetamol, amitriptyline, and bisacondyl due to stock out and stock in, and then was switched to tramadol. But on this last encounter, like I've said, he complained of this severe pain on the back, radiating to the scapula. He was put on morphine again, amitriptyline and paracetamol, and was also given dexamethasone. Dexamethasone 6 milligrams IV, BD for 3 days. While in the ward, we further engaged the patient, because what we had to do here was palliative management. We engaged the patient and to explain his condition. In fact, before then, the doctor decided to do a CT scan of the chest and pelvis, on which was done on the 18th March. Those findings, that CT scan of the chest revealed extensive bone lesions, multiple pulmonary and pleural nodal osseous and chest wall and bone metastasis. There was likely pleural effusion and lymphangitis, carcinoma. The pelvis revealed nodules in pararectal region, irregular nodules in both lobes of the prostate, and lumbar spondylosis, enlarged pelvic lymph nodes, and extensive bone metastasis. So in our engagement with the patient, we also explained and talked about these findings, which the patient expressed that when he knew that this was progressing, like it was explained when he first came here. And then we tapped into the social history. The patient revealed that he lost his wife to cancer of the colon in 2023. He also lost his elder brother, who also had cancer of the prostate. However, he died through motor vehicle accident. After the death of his wife, then the relative told us the condition changed and the patient deteriorated rapidly, such that at the current moment is mostly cared by his son and sister, the daughter-in-law. He expressed that he was worried over his pension payout from his employer of 32 years, whereby only about 300,000 was paid out to him out of 1,332,000. He cited government involvement as the cause of the problem. He was a meekly manager in that company, in that reputable company, and has since been, and the company has since been sold after his retirement. He says, together with his colleagues, they've tried to pursue this matter up to the ILO level without breakthrough. Was also present expressed concern over the safety of his cattle because stock theft in his area is very rampant. He said he has a special breed. He loves his cattle and has got a special breed, a bull there. The family says he always asks about his cattle. Every day he asks about his cattle. How are the cattle? How is it? So I was very much concerned about that. Another thing is worried about the welfare of his children. The last born had just completed Form 5 last year. One is unemployed and only 2 are working. When we talk further regarding what could make him comfortable, he expressed that he's so much willing to be cared for at home. He has got a decent house, which has everything he needed. He was a meekly manager at his place of employment, so he was able to build this beautiful house. So he said he preferred to be cared for at home, rather than any other place. Spiritual history, he's a member of Jehovah's Witness, believing in God, and said members of the church would visit him now and then. That was now unable to attend church due to the deteriorating health status. The patient appeared to be ready for any eventuality. Hence, he expressed his wish to be discharged home so that he could have a family meeting. In fact, he said he has had a meeting before coming to hospital where he expressed his wish. For example, he allocated land for all his kids, but then he said there's one of his sisters who kept on telling them that his illness is due to witchcraft. He said he wanted to go home and have a meeting with the family and further explain that he knew what was happening to him. In fact, during this discussion, he somehow regretted that he delayed coming to the hospital because seemingly they had the same problem with his brother, but they opted to do other things, to go for traditional care here and there. Hence, he said, if only I could have come to the hospital earlier, probably I would have been managed better rather than now to be told that it's stage 4. And then the advanced care planning, patient explained it or told us explicitly clear that he preferred to be cared for at home rather than in any other place. So hence the patient was eventually discharged home for ongoing pain management and counseling. Said the patient could be visited home and the family could always come to refill pain medication. And also noted that you would need to be referred to the social worker just for ongoing counseling. And then patient also be engaged with regard to a referral to home-based care. We made those options, but he said by then he wished just to be at home, and they will look at the issue on whether we eventually be referred to the home-based care team. Okay, I think that is the end of the case, but let me just go back again, because what made us to choose this case, Tim, was that when the patient was first enrolled to care, his condition was explained and the patient understood every bit of it. Hence, he knew what was happening to him. So when the doctor explained that now it has moved, spread to the lungs, and the bone is also extensively involved, the patient preferred to spend the last day of his days at home because he knew what was happening. To us, it appeared that the patient was ready for anything because he knew what was happening to him. And we felt that probably counseling was thoroughly done to this patient because, like, we look at it somehow that he had no issues that he felt maybe were outstanding, that if only I could do this and that. At his age, it appeared that, well, is a life lived, and he understood that probably now is at the end of his days, and therefore the best he could do is just to go and spend the rest of his days at home. Although, ladies and gentlemen, one would point out also that some issues that are not related to the illness, they also affect the patient. Because somehow the patient accepted that, okay, his wife is gone due to cancer. But what stood out was the issue of employment, because in his wallet, he kept some documentation which always reflected that my pension payout amounted to 1,332,000. But look now, I only got 300,000. And you will keep repeating that it's because of the government. Otherwise, the employer could have paid me. So also, he said they engaged the employer even if they had moved to South Africa. They went as far as that. And the employer told them that, hey, guys, go ask your government. I mean, I did all I could, but the rest of the question, forwarded them to your government. Hence, they decided to take the case to ILO level, whereby they couldn't get breakthrough also because of financial issues. They had to get attorneys, but seemingly because they were now retired, they didn't have that amount of money to engage the lawyer. Why I say this thing keeps on coming? If you look at it, it had nothing to do with the illness, but that was the thing that was bothering more than any other thing. And therefore, it means in as much as we care for patients with regard to their illnesses, but some other things that are dear to them, they also affect how they cope with the illness. I don't know whether the team could have comments on such issues, Mr. Mashlan. Thank you. I think that's what we can share, ladies and gentlemen. Thank you.
Thank you, Mr. Mngoni, and thank you, Manzini Hospital, for the case. Mr. Numalo has just shared a presentation on the patient that they have at the Manzini Hospital, a 72-year-old male with CA prostate stage 4, with one prominent issue, which is worries about his incomplete pay pension. But now he has accepted the reality of death and dying, but there are still these issues that are hanging around her life. So Mr. Numalo is requesting the team to have some input as they are taking care of the patients in terms of what can be done maybe to help this patient who is in his end of life, possibly the terminal phase with the deteriorating functionality status. So there are many issues raised by Mr. Numalo here. Some are spiritual issues, some are psychosocial spiritual issues. There's a lot of grief, there's a lot of self-blame and regret. There's a lot of issues of ACPs in terms of property, like the Kirkley and stuff. even though Mr. Nkumalo has said the patient has tried to break down and make the children get their shares, but there's still an issue when it comes to the KEGLI and the pension issue. And then the patient has decided to go and stay at home. But also we have spiritual dynamics where the sister doesn't believe, doesn't have the same belief as the patient. She's believing in witchcraft and she keeps on putting that ideas on the head of this patient. We are also seeing that the patient has issues of pain that sometimes has short-term effect treatment that we may need to deal with also. Another issue I've also picked from this patient is that this issue of pension and stuff might contribute to the moderate depression that this patient is going through. So we may need to see that. Another issue that was shared is the issue of scapular pain. Scapular pain etiologies might be two. One might be muscle strain, one might be internal organs. I'm not sure, maybe Mgunu will share after you share your comment in terms of clarifying if the cancer is metastasized to the liver, spleen, those internal organs, if it has metastasized to that one, because if that's the case, we might have the issues of scapular pain as referred from the internal organs. So it shows up as scapular pain, but in reality, it's an internal organ issue. So that one sometimes happen, but I hope, that's the summary I can share, team. So Mr. Nkumalo is requesting for your input on what can be done to help this patient deal with this lot of losses that she can't detach from. So I will leave this opportunity for you guys to participate here. What can we say? You can write on chat. Welcome, Mr. Cyprian. Good evening. Or is it good afternoon? You are welcome, sir. What can we say, colleagues, with this issue? What advice can we give? If this was the case in your table, what other issues you think you will explore to help this patient cope well with this situation he is going through at this point in time? If you will need some clarities, Mr. Nkumalo will help in that. But if you want to add a question, you can ask. If you want to say something in addition on what can be done currently, they've put a plan in place to maybe find a social worker for continuous counseling moving forward. Mr. Matsenjo?
Good afternoon, team. Thank you for welcoming me, Mr. Mahlangu. I think for me, it's a very wonderful presentation here by Mr. Sam. It's a very good one, so I say it's very informative, but I think according to me, because this patient is worried about the last one who's doing Form 5, that maybe won't get enough shares from the, no, not that, in effect, that is not well, he can't stand for himself. I don't know whether I'm clear in that. This last one, you still have like this last one, ngathi akakaphumeleli. So I think you can just involve someone, maybe a lawyer or a social worker, where you can get a bigger share on his property, because he's so worried about this last born. And I'm happy that he raised the end of life, that the patient is on the end of life. Then he's just preparing the patient. The patient is like, he's prepared. He's no longer taking any medication. For me, it's like, it's a good presentation. The following the patient very well. But my concern now is about the last born. Maybe if he can just shift most of his property to the last born, maybe putting some more money for him to take care of himself, so that he can die like peacefully if the time has come. That is all I can pass it paid.
Thank you, Mr. Matsenja. Mr. Matsenja is suggesting the issue of drafting the will, and then looking at issue of how he can best take care of this last born. Yeah, maybe that one can also help, because really, if he dies, possibly the elder ones might not take care of this last born. So maybe considering a lion's share on the properties through the living will, because yeah, that's true. Thank you, Mr. Matsenja. I will suggest, Mr. Nxumalo, as Matsenja say, let's encourage the patient to consider the will and be written down, so that he can safeguard his wishes for the last born through that document, because if that's not there, it will be challenging. Okay. Anyone else can share? There was a lot that was shared on this issue. I think in that will, he can even include the animals there at home, yeah, and all those things that he has, just for the family and to have a peace of mind. Yep. Anyone else?
Thank you, Tim. Noted.
Thank you, Mgo. Anyone else who may want to add something? I have a team of social workers in my room. You can't see them, but I can show you. They are full in their house. Let me show you. They are here. They are here. Let me show you. There are many of them. See them there. You see? Most of them, they are there. Let me show you. I have a team of social workers. You can see them. They are smiling. This one is Kanye, so this one from Christian University. I have many of them. There are many in the house. Let me show you another one. Yes, this one is Praise Mchono from UNISA. So I have a lot of them in the room. One is hiding. I will zoom it for you. Yes. So anyone else who may want to share something? Yes, I have all of them here with me. So yes, that's the one. That's the one. This one. This one, it's Tebandla, that one. I have all of them here. Yes, Cyprian.
No, I'm fine. It's just my network. It's like interrupted. No, that is my
Oh.
head is down.
All right. Thank you, guys. Anyone else who can have a question or suggestion with this case? We can appreciate that one. What would you do with this case in your table? What would you do? All right. I will also look at another issue. In our last two presentations, we shared something on another tool that helps us to be proactive in patients' care. I don't know if I can pull it up, but it's all about, let me see if I can share that tool with you now. So we were introducing the issues of the phases that the patient goes through when they are approaching death. So let me show you something. I will not present much on it, but I want you to remember these tools. They help us even to incorporate them into our daily presentations. They will help us to ascertain what we can do. Okay, let me share with this one. Yeah, I want you to see this one so that you can remember this one. I hope those who were there in that presentation will remember it. So let me do like this. So you remember this presentation. So this patient is in this trajectory, trajectory. So he is going through, he's going through this journey of the cancer journey. And one of the things we can understand about it is that it has this repeat decline, okay? So this patient Mr. Nxumalo is presenting might be already turning this side, or is about to turn this side. But looking at the functionality status of this patient, he might be going down because ECOG 3, it's a patient who's already bedbound, so he might be around here at the lowest level. Of functioning. So then this is a predictable, you can tell that this patient in few months was here. Tadazil, I think you with us when this American guy saying it's hours to days and days to weeks and weeks to months, months to years. So this patient might be weeks to months or days to weeks. Might not cross much weeks, and then he will be gone. I have not been there to see physiological functioning status of the patient, but physical functioning of ECOG 3, I may predict this patient is upon here, and you can tell that the distance from here to here is very short. So he is now approaching the end and is beginning to present the symptoms, accepting their reality. With Kubler-Ross grief that we shared last time, we'll look it again. We are now seeing that the patient is a more of bit of accepting, but a bit of bargaining, a bit of depression, a bit of, so in other areas, so he's moving a little, but he's more of going towards acceptance of their reality. And there are things that are very critical that we are dealing with that are so critical. Once you identify your patient to be in this trajectory, and then you go to these phases, I think you remember these phases. So if your patient is deteriorating, so we are planning then now to address anticipated needs of the patient. But this patient now, if then this patient might die in a few weeks or so days, we go to the terminal phase, and the actions that we take there, we are redesigning the care focus, and we are beginning to look at what needs to be done immediately, especially to ensure that the patient has physical, psychological, spiritual comfort. So, and we are planning now to deal with the end of life issues that we are anticipating that will come with this patient. So understanding this in your unit, understanding the palliative care phases, understanding the ECOG functionality status, and the palliative care phases, combining these can help you to plan for each patient's care. And you are able to discuss these issues at close range. So for me, this patient, I will say that now it's in the terminal phase. There's nothing we can reverse. It's days to weeks with this patient with us. And chances are he may die with all these issues and in anguish. So those issues that deal with the pension issue is to do some thorough assessment, finding the possibility to sort the issue at this point in time, so that the patient can be cancelled on the issue that should the patient be requested to cancel towards accepting the reality that the pension will not be paid, but then what the patient can exchange that with, because chances are he may keep on fighting on that, end up not getting anything. So I think it's an issue of inquiry. The social workers can go with the labor ministry and inquire on the processes that goes with this patient, so that the counseling around this patient can then be strategic to help the patient cope with this reality that really the pension was not paid and will not be paid again, if that's the issue. And then so that he can cope with this loss, helping this patient to cope with the reality that then it cannot get this 700,000 that is missing. And if this 700 is not get, what can be done? Look at this man. The fact that he's still focusing on the 700,000, yet there's a life that is pending to go now, chances are he will not enjoy the things that he already have at the expense of this money that he has no guarantees on he will get. So I will suggest a more thorough investigation in terms of what really happens when it comes to these payments and all these cases, so that then that social worker or that counselor can have a greater information and be able to find better help for this patient in terms of counseling him to deal with this grief of not paid the pension. And then the also issue is that it is common when patients will begin to blame themselves for not seeking help. And it's okay to help them recognize those emotions and help them understand that they have no role to play for the situation to be like what it is now, but they are still perfect and okay, and then still life better looking forward other than going backward. So we help them cope with their reality, because sticking on blaming on themselves, they will end up not facing and appreciating what they have, and they will die in grief and in harm. And this will continually hurt the family, because they will continue say, our father died blaming himself, A, B, C, D. And this sometimes holds him from allowing her life to go on to the next phase. So I think understanding them, why they feel like this, doing the thorough counseling on this issue again. So he has a multiple issues at this point in time. All these issues need to be dealt with, because sometimes they delay the process. Even though we don't want to hasten it or make it a delay, but these issues sometimes they delay the process and make the journey so bumpy for them. So I think counseling on these grief pains, the issues of blame. And then another issue I will suggest you can include is to get the church role at this manner. Fortunately enough, he has a good spiritual connection with the church. So getting the church playing a major role of coming closer to him, you may find that he even feels God has rejected him. And we know that Jehovah's Witnesses, they have some beliefs that they have, and we need to find out what role they play at this point in time in his life, and how best he can be supported to face the situation he's facing and cope better. So I think having the church members very close, especially the ones he is willing to sit down with, or the spiritual counselor or pastor. I don't know in Jehovah's Witnesses if they have a pastor, but that teacher, he may wish to come, and the rituals that are done in church or religious practices that he feels comfortable with, that they connect him with his God, can be amplified at this point in time. So he can find a space that God has forgiven him, even for not going to hospital, if he feels that he can't forgive himself, so that he can cope with the situation. I think we can play around that one. We can also deal with the issues of advanced care planning, discussing the reality that death is coming, but what things he can want to put in place, as he has said that now he's away, he will go, and what exactly things he would like to be done when he is not able to make the decisions. So those things must be put into place. So we can encourage him to draft those wishes, and then if he can have money, get the lawyer so he can have that document in place. And then he can even appoint the power of attorney. The proxy person who will stand for him through the power of attorney document, and then he can be able to do that. And then I think another issue is engaging the families, even though he is saying he's meeting the families, but having time with the families to get how are they coping with the reality that the father is going, and how are they interpreting it as a family, I think can help us at this point in time, because there's what we call thorough communication between the healthcare team and communication between the patient and the family and the team. And then that one goes together with what we call education. If you remember our last presentation, we said that one of the critical experiences, determinants of death and dying is communication. So if the families are not well educated on what they should expect going forward, you remember when we are looking at the palliative care phase on deteriorating, we are now beginning to plan for things that we are sure they are going to come. So we need to educate them on real issues that's going to harm. One of the issues is that we need to discuss issues of artificial feeding and hydration. We need to discuss issues of admission to ICU and the hospital in terms of medication. So those are the things we discuss, and many things, issues of death and dying, burial issues, all those things we may need to discuss. But the issue that is most important is the family preparation, educating them, finding out, so that even these ones with witchcraft could understand that this is not about witchcraft at this point in time, and what could be done better and what they can do to support, so they can stop inflicting the patient with witchcraft issues and raising the issues of stress. And then the issues of pension, I've mentioned it. I think another issue that the patient is going for ECOP 3 it means that ability to do ADLs and IADS has reduced. So then now he may need somebody to go to bank, he may need somebody to cook, he may need somebody to bath, he may need somebody. The issue for us, I can suggest we determine to know who is the forefront caregiver so that the social workers can face that patient, because he is indeed the most important pillar for this patient, because she or he does all these ADLs. I've heard that he's now living with the son, but the issue is the son doing all the ADLs and the IDLs for this patient. So we can put more counseling and education on what to expect on this patient and how best they can respond on those issues. So we need to focus on those issues to deal with this declining. So we can prepare them even when death is coming and dealing with those issues. I've talked a lot now. Maybe physiologically, I think another issue is even though most of scan and examinations might be weighed between the benefit and the cost of that on the patient. But sometimes getting to know exactly on where is the pain, what is the scalpel, where is the source of the scalpel pain. I think that one also can help us understand how best we can deal with that type of pain, because you may find that the patient has scapular pain, but it's not just from the scalpel, but it's emanates from the diaphragmatic and abdominal or internal organs. So we may find out how far the cancer is gone and how much damage it has, so that we can deal even with treatment that we are giving the patient in terms of knowing, will the patient be able to metabolize? Are we weighing between benefit and doubt? Especially Mr. Normal stated issues of the pain. Sometimes you may find that the medication response for a short period of time, it comes back. I understand, I'm not sure, Mr. Normal maybe will clarify the issues of availability of morphine at this point in time, and especially short and long-acting, long-release formulas. I'm not sure. But having the long release will be beneficial for this patient to avoid taking most of the medication. I think that one will help, and then those antispasmodic drugs that we may have to have them for this patient, and ascertaining issues of difficulty to initiate and manage sleep. Those issues we may need to deal with to find out if the patient is able to rest, and the issues of cachexia and anorexia. Yeah, all those issues. I think we have done a lot for this patient, but maybe strategically looking at the phases of the patient, and then put those tools together, coming out, okay, this is the plan, then discuss with the family on the plan going ahead, that now we are going to go, these are the realities that are happening, this is what we can expect going forward, even though we may not know when date will come, but these are the things, and this is how we can work together maybe on that. I don't know if I'm closing someone behind before I can shoot in the presentation for today. Anyone else who may want to add something? I have team of social workers here. They're looking at me. Look at them. Let me show you. Okay. Anyone else who may want to say something? Yes, praise.
Thank you, Mr. Manihau. Thank you for the presentation. Mine is on the issue of witchcraft. That the sister says or thinks that the patient was bewitched. I think that a medical doctor can sit her down and explain to her about the illness of cancer, just to educate her how, and educate her about the consequences of cancer on our health if it's not attended to immediately. I think I also noted that there's a history of cancer in the family. I think it's the wife also died from cancer, and also I think some of the relatives, if I remember well, I think they can be encouraged to scan, do scans, regular scans, just to be vigilant, and also encourage the whole family. And I also think that the sister, I think she's still in denial, hence blaming it on witchcraft.
Yeah. Thank you. That's one from social worker Praise Uchono. I don't see any hands, but this 3 minutes before I kickstart to the short presentation on the experiences.
Sorry, Mr. Mahlangu and
Yes.
Tim. Thank you
Yes.
so much for the additions. I think you've highlighted quite a number of them, and we do not. But probably it's worth mentioning that, like Mr. Ngumalo was saying, amongst other things, we are planning to refer to a social worker because today we are limited within the facility. So we are planning to refer to the social worker, one, to address the issue of the claims, but also we are working on, because if you do note, he did mention that they've actually taken this issue of their pension to the highest level at ILO. So then we need to work around him accepting the possibility of them not getting anything. But in the meantime, we did acknowledge the fact that probably the social workers could be in a position to say, can we take this issue further to the labor commissioner or whosoever to assist with that, but also to assist with the issues that are actually going on back at home, including the sisters issue. Otherwise, the issue of the caregivers, we have seen them, we have discussed with them the prognosis, also to find out how they are coping. So we are actually working on that one. So another issue that we still working on is the issue of how best can they be taken care of back at home, because that's where he prefers to be taken care of, including issue of referral to the home-based care team. So basically, I think that's that will be my addition. But also just to make looking at the topic yana mohla, Mr. Mahlangu, we did acknowledge the fact that it is actually addressing dying and death across a lifespan. Unfortunately, considering our time, we couldn't come up with almost 3 cases at least to give us a view or a differentiating them between what happens during at early stages, adolescence, probably what happens, why is it different from how my elders experience dying. But we did look at generally what normally happens, in as much as we are not seeing much kids and much adolescents, but we did look at our limited experience to say, normally what we have noticed with our kids, they probably they approach it in a different way. Firstly, it would be the issue of their understanding of death. It's probably different from adolescents. It's probably different from adults. They may view that as something that is temporal. Probably it's because of the language that we normally use to say somebody has slept, somebody has passed on, somebody has gone to a better place, somebody is up in the stars. So they always view that as something that might be there, but probably somebody might still come back. But also with our kids, what we have noticed is that approaching that for them, it leaves them in a situation whereby, in fact, going through the disease process, it leaves them with a lot of issues, which is why we end up having angry kids. Why is my life different? Why can't I be like other kids? Why can't I go to school? Why can't I have a normal life? Sometimes they get angry towards their parents, angry towards, if they're oriented towards any super being, they get angry towards that. But what they normally do, some might want to isolate, but some might want to spend more time with their friends because they are afraid being in a space whereby they feel like this is just a space whereby I am alone. So they differ. Some want to isolate, some want to spend much time with their friends. But getting closer to their end of life, like getting closer to the eventuality, you find that even if they are in a room, they don't want to be left by their parents. Most of the time, it's their mothers. They'll be like, no, don't leave me. So the mother now has to be there like 24/7. Even if you were to go out for a moment, they'll be like screaming, Mommy, I'm scared. Final moments, they'll be like, please hold me tight. I'm getting scared. They know that it is actually happening. So they want the mothers to be here. They don't want to go into a space they are not sure of alone. So they want the mothers or whosoever, the loved ones, to hold them tight. But with adolescents, they get to appreciate, to say, yeah, there is death and you are going to a space you do not know and you know it's actually a finality. But how they handle it, it's also different. Most of them, you might find that they isolate as well, but most of them, you find that they want to spend time with their friends. Some, they are on their phones they try to escape reality. They know it's a finality, so they kind of try to escape reality. It's a different case than with adults. There's also mid-adults. There's also the older ones. They are quite different. But with the older ones, what we have discovered, if we have had enough time, palliation and all that, they perceive death as them transitioning to a world whereby they are following or they are going to be with the ones that they have preceded, the ones who died before them. So those ones, they even make plans to say, if I die, this is how I want things to be done. They have a chance to say, to live their affairs in order. They have a chance to say their goodbyes. They have a chance to kind of come to terms with this. So basically, I think that was our discussion. We would have loved to have probably 3 cases to kind of zero it down to say, this is what happens during probably early stages. This is what happens during your adolescent and adulthood. I think that should be my comment.
Thank you. I want to clap hands for you. You see, you are the great team. Thank you, Manzini Hospital, for that wonderful presentation. So let me just summarize today's case by giving you a snapshot of these experiences of these groups. I will not dwell much on it. Please note that if you are registered with our platform, you will just find it right there, both the case and the didactic presentation. I've already uploaded it. So allow me to take this 26 minutes just to share these 10 slides. I will not explain much. I will just go through the concepts. Otherwise, just to share with you what is really happening across these 3 groups, just to add what Thandazile has said. I hope we have learned a lot today. So let me just share this with us. Ooh-wee. So it's a build up on our last presentation. So if you remember last time we had a presentation where we were looking at the experiences. And one of the experiences was developmental stage of the client or the family. And then I mentioned that I will come back today with a presentation on the developmental stage, on how they influence the patient. So I'm trying to do that now. So we are going to look at the death and dying across the lifespan, understanding the reactions and needs of this person. So Thandazile have already mentioned it. I will not dwell much on this, but we are going to look at their reactions to death across the childhood, adolescence, and old age, okay? So, and look at their needs. So, yeah. So I will not look much on this, but what we need to understand about these people is that children understanding of death changes as they develop. So as they grow, as Thandazile have mentioned, as they grow, some they think you will come back, even if I can kill you, I can raise you up again. Before the age of 7, they may not grasp it as a permanent thing. They may see it as temporal. Thandazile have already mentioned that. And grief can show through play and behavior changes like irritability. So when the child is grieving, so if we are dealing with children, so when they're taking off their mama, we are dealing with a child who's sick. Look at when they are playing. Social workers or those who are dealing with children will put toys and give them the opportunity to play. So you will see a child who's irritable, then you can tell that there's a lot of grief happening with this child. So, provide honest and simple expression about death, reassuring them of love and safety to ease their fears. You need to give them hope. Tell them the truth, but with hope. See, the D word, let's not run away from death. Let's mention death, but let's not be brutal for them, but into their cognitive level. So, You may see them with certain common reactions like separation, fear of abandonment, magical thinking, So these are the children. We need to understand as they go through, these are the things we need to, but even they are children, they need to know they are still beginning to understand. What is this? I have a son in the house who keeps on asking, what is happening? Why is this? Are we going to die? Does it mean when we die? So they ask a lot. So we need to understand those questions. And then we have when we are supporting these children, one, we need to have play. Two, it's art therapy, have them be creative, have those toys that they will create, jigsaws, all those things that will help them be creative, things they can play around with, and then help them tell stories. Those who can begin to tell stories, allow them to experience that way. And sometimes when it comes to parental guidance, we talk of open communication, okay? We are encouraging those discussions about the feelings and validating their emotions and validate feelings, acknowledge emotions like sadness, anger, confusion, and reassure them it's okay to feel that way, okay? And then maintain my routines, keep constant routines for stability and sense of control. So allow the child to have a stabilized routine. Don't change things now and again. Allow them to have those routines. Okay, that way the children are gonna cope. And then with the adolescent, standards have finished the whole presentation at once. So they understand the mortality, causing grief and spiritual questions. And at this patient, the grief varies. And at this point in time, peers or friends, they matter a lot. Teenagers like friends. You can agree with me. When we were growing young too, we liked going out to play. So even these adolescents, they like playing. So having their friends around is okay, even if admitted, having their friends company, acknowledge their feelings and respect independence. These ones, they want to take control, they want to have their room, they want to have their time, So, yeah. So they have abstract understanding of thoughts, and sometimes they have grief, intense grief and anger, denial, anxiety, and depression. So their journey, in the Kubler-Ross journey, they are so much aggressive. And sometimes they may commit suicide, these teenagers. So you need to watch closer these challenges and help them to have time to sleep and have time to rest. Sometimes they even go to anger strike, trying to kill themselves. So suicidal thoughts, as their reaction to this loss or experience of death reality, then they may do that. And sometimes having essential support for them, like support groups, having creative activities like journaling, art, sports, are useful for them, especially for what this teenager loved to do. And then sometimes counseling helps them to process emotions and prevent lasting grief. So those are the things we need to understand with these guys anytime we have. And even if it's not direct them who are sick, the family members of these children, if they are the siblings of a child, or they are children of a mother, like these men we are talking about. So we need to understand this adolescent is going through this, knowing that my father is going to die and I have nothing to do. Then the Kubler-Ross journey for this patient, the grief reaction might be a high tornado than you may think of. So they can even kill themselves on the death of their parents. And then to facilitate this, I've mentioned one, we need to have therapeutic interventions. We talk of a MAC group and individual counseling, encourage a MAC connection with friends, and especially friends who can understand what the patient is going through. And we create a MAC memorial project that can be helpful, have things that can be memorial for this patient, and then respecting the privates. And sometimes the privacy doesn't mean neglecting the adolescent child, because really suicidal issues are real at this point in time, where I am now. And then we talk of the elderly ones, like the real case we have been doing today. So these patients, they go through a lot of things too. And their reactions include acceptance, fear, anxiety, intensified physical and cognitive decline. I think we can reflect to Mr. Ngumalo's case today that really they go to acceptance, they have fears, they have anxieties, and these is intensified by the physical and cognitive decline, like this men we are having. And they reflect on life and prepare for the end. Like this client, Mr. Noel has begun to reflect on what has happened, and then the reflection has these issues of grief on the unpaid pension part. Looking ahead again, he's moving. So he's kept in between moving forward and pulled back. So we need to help him take a way forward journey. And sometimes the conditions, isolation and finances can complicate grief. So what this patient is presenting, Mr. Ngumal, is a real issue. And we need to help him detach from it and move forward with it, because the conditions, the isolation, sometimes they go through abantu abadala, the finances, and they complicate the situation of loss. And dignity, comfort, legacy. What have I worked for? And for that man is complaining of that. What have I worked for all these years? Nobody's recognizing who I am. What have I done? My purpose was what? This Erikson developmental stages. Yeah? So the patient is there where there's grief, because now there's nothing that of legacy for me. And then sometimes spiritual support at this point in time is crucial, because that's when if you lose connection with what you can touch with your hand, you need something that cannot rot, something that cannot be taken away. And that only thing is the supernatural being of that person. If it's God, if it's ancestors, whatever this person can connect better with, that cannot be taken away from him. So spiritual support at this point in time is very crucial. And for these patients, what we can do with them, most of the time, promoting dignity and comfort for them. Make them get that dignity, make them feel valuable, make them feel that even cancer is dealing with them, but they are so special. So that when we teach the families to report everything, no chicken must be slaughtered without the permission, no clothes must be sold without the permission, no food must be given to the patient without the, no bathing, no turning on the bed, even if not communicating. Nothing must happen on the patient without their permission, even goals and directions. So we encourage them, because of what? We are promoting dignity and comfort. So we are looking at symptom management. Let's deal with this scapular issue, because if it's an internal organ issue, we need to anticipate what we call ascites that might come, and then we need to educate them on how to deal with it. We are dealing with well-being of this patient. So we need to focus on those issues at this point in time. And sometimes encourage legacy project and spiritual care. Some will want to start something, a charity work. Some will want to do something for their great kids, and then again and again, let's go to spirituality. If as a healthcare professional, you are not aware of your own spirituality, then it's a challenge. You need to work on it, because sometimes you need to be aware of your own, so you can help these people to cope with. And then also we understand that palliative care enhances equality of life and prioritizes the dignity and respect with practical and emotional support. Okay, what can we do for the patients? Okay, so at this point in time, I say palliative care, palliative care, palliative care. Manage pain, reduce discomfort, and address emotional distress. For these ones, focus on those issues. I've mentioned the issues of legacy projects. Sometimes they will want to create books. Sometimes they want to do something that they want to do. Some will want to leave some recordings. In the graves, there are golden ideas, visions, solutions. If you make them feel the dignity and value them, asking them lessons. If you want to teach your kids, what would you like to teach them lifetime, even if you are not here? They can learn and listen to that. Would you like us to make a recording, you teaching these kids and others outside there about the life you have gone through, on other issues you want to, I don't know what to make them valuable at this point in time. And they will begin to see life better and appreciate the destiny with good spiritual support. And then I cannot mention it. We offer guidance on issues like this. Patient is complaining that if I could go to hospital, maybe I would not be here. So we guide them depending on what their spirituality, prayer, the rituals that I've mentioned before. And then another issue that we need to understand about the journey of these people. is that there are cultural consideration in death and dying. Whether you are a kid, whether you are an adolescent, you are what, there are these issues you need to deal with. And cultural background shape the experiences of death and dying. All right? And grief. You need to understand what is the cultural background of these people. The rituals provide mourning frameworks and influence funeral practices. So these are the things you need to understand. How do they do it at home? How do you handle death and dying at home? What is your interpretation of it? How has been experienced with your wife, with your brother, and what has been your experience in this cancer journey? They will affect the patient's death and dying and grief process. And then afterlife beliefs. Do you have afterlife beliefs? What do you believe in? And then all those things will help us help them and do that. And it's very important to have an open dialogue and ensure understanding of needs and differences. All right. So when we are doing this, one, we need to offer comfort and structure, support families by understanding them, the traditions. What are they doing in our culture? How do we go about these issues? And need to be very sensitive to these issues, non-judgmental stand, be sensitive to the norms and values of these patients we are dealing with, and we need to use open questions. And then understanding, we need to, the beliefs impact decision, prioritize family wishes. So we need to understand these things, that my beliefs impact my decisions, and we always need to prioritize family wishes, and especially when they are aligned with what the patient wished. So this one is very important, especially family wishes. It is easy actually to prioritize them, knowing what the patient wished, but without the advanced care planning in place, you find that then now family priorities and wishes, sometimes they are totally against what the patient wished for. So having the advanced care plans in place and documented deals with all those issues. So practical strategies for support: have empathetic conversations, validating experiences, provide grief resources. Remember self-care as a healthcare professional, because you also go through the same problem. So we will see this topic, I hope, next year. And then education normalizes grief. All right, so educate the patient, educate the family, let's educate one another as team. For that reason, we are here. So it normalizes the grief. It doesn't make it a witchcraft issue. And then it's very important to listen and empathize and educate. Those are the three things. You listen, you empathize, you educate. The communication is backbone of palliative care. It's what we call comprehensive, clear communication is the backbone of palliative care. Listening is golden in palliative care, then empathizing and educating. Those three things, mother of palliative care. All right? Maybe I would like to say it's very critical to recognize the diverse needs across all ages and across all different individuals. By promoting an open communication and empathy, we can support grieving individuals with compassion, ensuring dignity and respect in the face of mortality. A compassionate society benefits everybody. That one we 100%. So one thing you need to understand then is acknowledge diversity, cultivate empathy, and build a supportive society in the communities, in the facilities where we are found. Let's connect, let's be connected, let's form teams, let's have a good community supportive network. In that way, we are going to have fostering a good, supportive care. No, I wanted to read for you these last words of mine for this presentation for today, that encourage utilization of support groups or counseling services. So when we are talking about this, we are also talking about the church can be a good supportive group for these patients if there are no support groups as yet. Survivorship groups, they have. Encourage participation in activities that promote healing and promote a sense of normalcy. You know, it's very important that we don't deprive patients of the ability to do activities. We usually say, allow the patient to do things for themselves as long as possible, and then allow them to do activities that promote healing and provide sense of normalcy. Don't feed him if he can feed himself. Don't brush his teeth if he can brush his teeth. You know, don't talk for him if he can talk for himself. So those activities that are always there in the house that he can do, let him or he do them for himself, so he can get healing and have the sense of normalcy, of being normal, and offer ongoing support and check-ins to show consistent care. Even if they are home care, there's what we call a hospice at home televisit. It has been a new model in palliative care identified through COVID, that even if we can't have a car to go out there in the field, like the Manzini Hospital, we can go there. But if the institution can provide a telephone, let's do the ongoing support. Let's offer it. Let's have some time schedules. In this day, we are visiting those who are outside hospital telephonically, checking them, showing them psychological support, emotional support. How are you doing? We still love you. We want to find out how are you doing. That's all we are doing today. So those things are very key for all these groups we have been talking about today as they go through death and dying. I think I was trying to summarize everything for you of what we have been doing. So I think with this patient we have done, Mr. Mazia, you can adopt this what we have done today. Even if you cannot come to Monene, I don't know Monene has a telephone. I'm closing my eyes there. But if it's available, that will be +1 for the palliative care unit there. Have them who come into hospital, initiate the program whereby you are going to visit them telephonically, other than visiting them when they are defaulting to come, but just checking them. You know, today I want to talk with you. Today I want to talk with mama. Today I want to talk with a cousin. Today I want to talk with, so you can support them through. Today I want to chat with the patient. You know, even if before they come to hospital, they have a good experience that, you know what, these people, they love us. Even we have cancer, they love us. They appreciate that. My experience with this ongoing support and follow-up is that the patient really appreciate support and follow-up. Even if it's telephonical, they really appreciate to hear our voices, you know. Like we want to call one another in a family, like they become part of us. So let's continually support them. If there's no support group, let's encourage the church. Find the church, get the number of the pastor. When they leave the facility, get the permission from them. Can I call the pastor with you? Can I call your inyanga or traditional healer? So we can say whatever this patient is believing in, so we can connect them and have a strong supportive system for them. That's when we are going to have them having comfort and experience. That's what I can say. I have 5 minutes for anyone who may want to add something on today's presentation and today's session. It was a great session. Yes, Tandazile.
Yes, Mr. Mahlangu. Thank you so much. Thank you so much for everything, the presentation, the comments, and your latter presentation. That was quite informative. Thank you for that. Probably, I think what you are bringing up now, the issue of calls. I know we used to do those, but it wasn't in a structured form. We would do them haphazardly, such that we couldn't actually evaluate to see how effective they were. But probably, I think we need to reconsider that. Yeah. Then we have another client recently. I'm getting back to the issue of support groups, support systems. You know, this one she's a staunch believer. She believes in God and everything. But you know, when we tried to check if she would love to have anyone from church, be it the pastor or anyone, she said no, thank you. So I think what I wanted to highlight is that we really need to assess, check with them. Don't assume because we've heard them talk about God, heard them talk about church, then we shouldn't just assume that they need them. They said no. Then we try to check what could be the possible issues. One is that the client needs time to rest. also it's the issue of false hope from them, because we are believers, so we would want to say God will come through for you, God will heal you, and she's dealing with this thing, with this whole thing in a whole different, and from a whole different angle. So they felt like, no, I think we are doing fine. So we really appreciate their support, but at this point we think we are doing okay.
Yeah. Thank you, Tarazile. I'm telling you, through my experience now in palliative care, televisit will do magic for your facility. You will see the difference with those patients. You will get to be proactive with them. Some will discover that, Sister Tarazile, I've done this, and this is what is working, this is what is not working for us, this is the challenge you are facing now. Then you advise them even ahead. Some of them will not need to come to Monen spending their last cents. You know, you just advise them telephonically and do some follow-up. Sometimes you have given them medication. Check them a few days down the line. How are you doing? But need to have it systematically structured for you. And then you have a plan. How are you going to do it? Who are you following? How are they performing? Document their inputs. And then at some point, do some customer feedback. How was our telephonical? How has it changed your life? And then it can help you even as a unit to advocate for more resources for that program, you know. Yeah, it can help you. Each churches have telephonical systems. They say send your prayer online. You have seen that. So it has an impact. So even in palliative care, telehealth has done that. For those who have data, you can even have virtual calls, WhatsApp calls, virtual videos, chat with them. For those who don't, it's very powerful. It's equals to a physical visit in effect. Thank you so much. Indeed, spirituality, we need to do that assessment. And before you initiate any intervention, get the consent. It's very important. Otherwise, you'll be an enemy for that patient. Thank you, Tandazini, to clarify that. Oh, no, madam. Actually, now I remember you owe me something, but we will talk in the back doors. Okay, anyone else want to comment? Zinhle say, wow, that was very informative presentation. Thank you, Zinhle from Nazarene. You are doing a great job there. You are not alone, we are with you. Remember that always we are with you. With praise and Debanga and Skajizo are with you, Zinhle, and your team. So without wasting of time, Zinhle, how are you? I want to expose you today. Oh, no. Oh.
This is very cruel of you.
It's nice to have you, madam. I want to request you something special today.
No, okay. But I'm not at work. I'm on leave these days.
Yeah, but you'll be back on the 7th of May, right?
I guess so.
Yeah. Can you have something delicious for us? A case presentation from one of the best hospitals, RFM Hospital Palliative Care Unit.
Okay, I think I can try that.
Thank you so much. I will share with you the case presentation template right today, so you can begin to work around on it going forward. All right. Thank you so much. Thank you so much, Manzini Hospital. Mr. Ngumale, thank you so much. Arios, for the work done, and continue that great work. We like your work. May God give you the strength. We can see Mr. Zigalala from UNISWA. Thank you so much, Mr. Zigalala. We thank you. We can see Umkanto. Thank you so much, Mazia, for joining. And others from my team, thank you so much for joining. And my social workers, thank you so much to be with me today. Thank you so much, everyone. Let's meet on the 7th of May. We will be looking closer to the ethical issues associated with death and dying. What ethical issues? How can we escape those dilemmas that are there? We'll be looking at them closer. How do we deal with those ethical issues of death and dying on the 7th of May? And we'll have a wonderful case presentation from our great hospital, RFM Hospital, Palliative Care Unit, led by our team member, Zinhle Zwane. Thank you so much, colleagues. Let's meet on the 7th of May. Bye-bye.
Bye.
Oh, Mhlan, I didn't see you. Oh, no. Okay, thank you.